Rising prescription drug prices have outraged the public and gotten the attention of lawmakers. So we set out to answer the big question: why do drugs cost so much? To start, let's identify the players in the prescription drug supply chain. They are the drug maker, the wholesaler, pharmacy, the pharmacy benefit manager, health plan sponsors, and you. The pharmaceutical companies are obviously at the top. They research, develop, and manufacture the drugs. From there, drugs end up in large warehouses, stored and distributed to pharmacies and hospitals by a wholesaler. The pharmacist is the person you actually see in this equation. They buy the drugs from wholesalers and dispense them to patients. The next step is one fewer people know about. Pharmacy benefit managers are hired by insurance providers to handle prescription-related claims. They also use millions of patients they represent as leverage to negotiate rebates from the drug makers. If a drug maker agrees to give a big rebate, their drug gets better placement on the formulary that says which drugs are covered by the insurance companies and which are not. In this way, pharmacy benefit managers say they are saving health plans millions. They also decide which pharmacies are in-network for patients. Your health plan sponsor, whether that's your employer, an insurance company, or a government program like Medicaid, likely pays a pharmacy benefit manager to run prescription drug coverage for them. You pay the health plan sponsor a premium for the administration of these services, and they pay the pharmacy benefit manager. The consumer is you, or in this case, Bob. Bob pays his premiums and deductibles to insurance and likely just pays a copay or cost share percentage when he goes to the pharmacy counter. He's impacted by the decisions of his health plan and pharmacy benefit manager because they may decide not to cover a drug that's prescribed to him. So let's look at who's making money in this system. Drug makers set a list price for their products, enough to recoup research and development costs, cover the cost of production, and of course, make a profit. Let's say this company lists a hypothetical brand name drug at $160 for a 30-day supply. The joke in the industry is that $160 isn't what anyone in the supply chain will actually pay. This is where the negotiating starts. Wholesalers negotiate a lower price that they are going to pay for the drug. In this example, $150. Then they sell the drug to the pharmacies for a slightly lower discount, like $155. The wholesaler made $5. The pharmacy is going to add a markup for profit as well and then sell the drug to the consumer, with payment usually coming from a combination of the consumer and their insurance. In this example, let's say the consumer pays a $20 copay, and the pharmacy bills the remaining $140 to the insurance's pharmacy benefit manager. The pharmacy made $5 as well. The pharmacy benefit manager now turns around and bills the consumer's health plan for that $140, plus a spread, or profit. Sometimes this is a set agreed upon amount, like a $5 per prescription fee. But sometimes your health plan doesn't really know how much they are paying above what the pharmacy did. In this case, we'll say the spread is $20. So the health plan pays its pharmacy benefit manager a total of $160, which, in this example, was the original list price. The consumer, of course, is paying premiums to their health plan as well. The more insurers are spending on prescription drugs, the more they are passing that cost along to their members through higher premiums, higher deductibles, and higher copays. Finally, the drug maker rebates are distributed. Remember that pharmacy benefit managers negotiate with the manufacturers to get the biggest rebates. In this example, the drug maker has agreed to give the pharmacy benefit manager $50 back. That leaves the drug maker with $100 out of the $160 list price. The pharmacy benefit manager can now pass all, some, or none of that rebate along to the health plan they work for, depending on their contract. So with the $20 spread, the pharmacy benefit manager could make as much as $70 on this hypothetical drug transaction. Or they could just keep the spread and the health plan sponsor would save $50, bringing the cost of the drug down to $110 in the end. But wait, if drug makers know rebates are going to eat into their profit, what's to stop them from raising the list price higher to begin with? Critics say all this negotiating, meant to save money, is actually driving up the list price to the benefit of everyone along the chain who makes a cut of that total. But the pharmacy benefit managers say they'd actually make more money if prices were lower. If drug makers wanted to lower prices, they could, the PBMs say, because the manufacturers are ultimately in control at the top of the chain. In Sunday's Dayton Daily News, we take a look at some of the highest priced drugs on the market, the specialty drugs that can total more than $100,000 a year for some patients. And Monday, we dig deeper into the pharmacy benefit manager industry, accused of creating a shadowy system in which no one knows how much the middleman is pocketing.
Created using Powtoon.